Hello, everyone. Today we're going to be talking about Achilles tendinitis. Achilles tendinitis is an umbrella term that refers to three conditions. The first is insertional Achilles tendinitis, the second is retrocalcaneal bursitis and Hagelan's deformity, and the third is mid-portion Achilles tendinopathy. It can be a little confusing clinically and there can be overlap, but for the most part, these are three fairly distinct conditions. However, it's very common for patients to have a combination of more than one of these. This slide basically shows the Achilles tendon, which inserts right down into the calcaneal tuberosity. Now, the first condition I talked about, Achilles, insertional Achilles tendinopathy, is a pathology affecting the calcaneal tuberosity in the insertion of the Achilles tendon. The second condition, which is retrocalcaneal bursitis, I will show later on a different slide. The third condition, which is Achilles tendinopathy, also known as mid-portion Achilles tendinopathy, affects the body of the tendon quite a bit more proximal than the insertion. Talking about the first condition, which is insertional Achilles tendinitis, this is basically pain and thickening at the insertion site due to repetitive trauma. It's commonly seen in the demographic of middle-aged and elderly patients who often have tight gastrocnemius soleus complexes. It presents as posterior heel pain, stiffness, and burning and pain while wearing shoes, which is due to pressure over the site of inflammation. On examination, they'll often have tenderness at the midline tenderness over the insertion of the Achilles tendon, and they can have progressive bony enlargement of this area. X-rays are usually more than sufficient to make a diagnosis and will show a calcaneal spur uh, at the site of insertion, and there can also be intratendinous calcification at the insertion. Rarely, MRI and ultrasounds can be performed, but this is mostly for academic purposes and it shows the amount of degeneration. Treatment can be non-operative and operative. Non-operative is always the first line of treatment. It usually consists of physiotherapy with eccentric training and gastrocnemius soleus stretching. There can be various modifications to the shoes, such as heel sleeves and pads, which is the mainstay of non-operative treatment. You can also use a small heel lift. Uh, in case all other modalities fail, you can use a locked ankle foot orthosis for 6 to 9 months. Uh, Injections that we can use are PRP injections. There are other experimental injections also. We should avoid steroid injections due to the risk of Achilles tendon rupture. If all of these fail, we can then move to an operative method. First can be excision of the bursa and debridement of the diseased tendon. Whatever prominence of the calcaneal bone is there can be resected. These methods can be used if less than 50% of the Achilles tendon need to be removed, and it's often done through a midline, lateral, or medial J-shaped incision. Now, if we need to remove more than 50% of the Achilles tendon insertion while doing the debridement, we may need to do a tendon augmentation or transfer. It may also be required in heavier patients with a more severe disease. FHL or flexor hallucis longus transfer has been associated with the best results if this has to be done. Next entity we come to is retrocalcaneal bursitis and Hagelan's deformity. It's important to understand which is which. If you look at the image at the top on the right hand side, there are two different bursas. One is the retrocalcaneal bursa. This is a deep bursa. This is anterior to the Achilles tendon and between the Achilles tendon and the calcaneum. And one is a subcutaneous calcaneal bursa at the back. Now, in retrocalcaneal bursitis, it's the first one, the deeper bursa, which gets affected. And in Hagelan's deformity, if you look at the lower picture, you develop an enlargement of the posterior superior tuberosity of the calcaneus. So this is a bony problem as opposed to the soft tissue or bursitis or the retrocalcaneal bursitis. This is also known as pump bump. So these two are seen in younger patients. The pain will be maximum anterior and 2 to 3 centimeters proximal to the Achilles tendon insertion. So if you remember in the first condition, the pain was maximum at the Achilles insertion. Here it's a bit proximal, 2 to 3 centimeters proximal to the insertion. There'll be fullness and tenderness medial and lateral to the tendon, pain with dorsiflexion, and bony prominence can be found at the Achilles insertion. Imaging is usually a radiograph is mostly sufficient. A lateral view will show the Hageland's deformity. This X-ray shows a patient who is unfortunate and has both these entities, and like I mentioned, it's quite fairly common to have an overlap and simultaneous affliction with more than one of these entities. So at the top, you can see the Hageland's deformity, which is a bony abnormality at the posterior superior tuberosity of the calcaneum. Lower down, you can see there is a spur and there's also some calcification within the insertion of the Achilles tendon. Treatment follows a similar schema to the first condition. Non-operative is the first line with activity modification, ice, external padding of the Achilles tendon with modified shoes. Injections, again, you can use PRP or experimental injections, but you should not use steroid injections because these can increase the risk of Achilles tendon rupture. Operative is removal of the retrocalcaneal bursa, debridement of the tendon, and resection of the Hageland's deformity. Again, these are only indicated if all non-operative methods have failed, and the technique is again through midline, lateral, or medial J-shaped incisions. Coming to the last condition, which is Achilles tendinopathy, also known as mid-portion Achilles tendinopathy. This is seen in, again, 30 to 50-year-old patients, and it's often an overuse injury. There are several mechanisms which have been proposed, such as overuse or poor tendon blood supply, genetic predisposition, an imbalance of the ankle dorsiflexors and plantar flexors. The problem here is in the mid portion of the tendon. So this is usually 3 to 6 centimeters proximal to the Achilles insertion. Generally, the patients will have pain, swelling, and warmth. Like I said, 3 to 6 centimeters proximal to the Achilles insertion, difficulty running. On examination, they'll have tendon thickening, tenderness, and warmth, again, quite proximal to the insertion. And there's usually pain through the full range of movement of the ankle joint. Imaging, it's only revealed on MRI, and on MRI, you would see a thickened tendon and intrasubstance intermediate signal intensity. If there's a chronic rupture, you will see a hypoechoic region between the tendon ends. Once again, the treatment is very similar in the sense that we start with non-operative management, and this is by activity modification, physiotherapy, heel lifts. In severe cases, you can use a cast or removable boot. Um, Usually, non-operative management is successful in around 65 to 90% of patients. There are also evolving treatments such as glycerol trinitrate patches, prolotherapy, and aprotein injections, but there is not really much evidence regarding the use of these. If these fail, you can do a percutaneous tenotomy. This is usually indicated in mild to moderate disease. You make a longitudinal tenotomy in the degenerative area. You strip the anterior Achilles tendon with a suture, freeing any adhesions, and you can often combine this with the dorsal wedge calcaneal osteotomy. If it's a moderate to severe disease, you often have to perform an open excision of the degenerative tendon, and you have to tubularize the rest of the tendon. This is usually successful in around 70 to 100% of cases. The worst case situation is if you have a degeneration of more than 50% of the Achilles tendon, and often in patients who are more than 55 years. Here, the tendons that we use for transferring are either the flexor hallucis longus, the flexor digitorum longus, or the peroneal brevis tendon. In order to be justified doing this sort of drastic procedure, there would have to be MRI evidence of diffuse tendon thickening, and without a focal area of disease which can be targeted with a tenotomy or a excision. Often, this is also used in patients who have subacute ruptures. So, patients who had prior Achilles tendinopathy and then they developed a subacute rupture. In these patients, you could use a tendon transfer. So that brings us to the end of this brief summary of these conditions. They are fairly complex and there's a lot of evolving evidence regarding them. We've tried to summarize it as briefly as possible. I hope you enjoyed this and that it was useful. Thank you for listening.